We move on to the next speaker. I have the honor and privilege of introducing Dr. Chandrima Paul, the chief instructor of this particular course. She is one of the very first PhDs in ophthalmology in all over India. She was the past General Secretary of the Glaucoma Society of India, the President of the Kolkata Association of Ophthalmologists. Ma'am is the Director of BBI Foundation. She's a key opinion leader in the field of glaucoma, but she's also an ardent pianist and an avid debater right from her school days. Over to you, Dr. Chandrima Paul, ma'am, for speaking on glaucoma artifacts.
Thank you very much, Shubhranshu, for those kind words. I see in the audience there Dr. Shushmita Kaushik. Can you please join us on the dais? You have extensively worked with the OCT, so please come up to the dais. It would be very informative for everybody. So, there are enough of chairs here, actually. Okay. So, this is basically a screenshot of Dr. Joel Showman's slide at the GSI webinar in 2020, where he said that OCT abnormality predicts visual function conversion in glaucoma suspect and preperimetric glaucoma. Ganglion cell complex focal loss volume was the best predictor of visual field conversion in 513 GSPG eyes, followed for an average of 52 months, in which 82% of visual field conversion preceded by abnormal OCT and 23 plus minus 17 month lag between visual field conversion and OCT abnormality. So on that note, by one of the founders of OCT, we move on to what we need to actually be careful about when we are actually using the OCT. So the factors affecting OCT scan quality. Patient dependent, we have the media opacities and pupillary diameter. Operator dependent, centration, signal strength of acquired image. Device dependent, acquisition speed, database related, and clinical paradigm of OCT scans. Coming to patient and disease dependent, pupillary diameter less than 2 millimeters does not really give you a good picture. Cataract can diminish the fineness of the OCT image. Dry eye, definitely you've got to take care of the dry eye. And the eye blinks which come in between, in the absence of an eye tracking system, the acquisition process continues uninterrupted even in the presence of blinks. So you've got to be careful about that. I'll talk about those with pictures a little later. So patient and disease dependent floaters. If you see there, when a flotus is located on the scan circle, a vertical shadow of the signal attenuation interruption is there, visible in the corresponding area of the circular tomogram, and that can actually affect your OCT scan and give you a misinterpretation of what's going on. Effect of blood vessels, if you see shadowing, as you see out here, shadowing on segmentation. Next come vessel breaks, as you see on the B-scan image, indicating problems in scan acquisition, and of course segmental errors can actually reflect as artifacts which can mislead your diagnosis. So poor signal strength, so you've got to be careful what is the signal strength before you actually label a patient as glaucomatous. Something like this, as you see on your left, that is 34.8, could mislead a clinician. So operator dependent artifacts include truncation of the acquired spectral domain optical coherence tomography image, that is all edges of the image were not seen within the window as you see out there. And the same image, when I show you here, see there is a drastic change in your pie chart that you see, and even in the graph that you see the double hump pattern and the rest of it. So misinterpretation of artifacts, localized losses of RNFL or macular thickness classified as normal due to averaging of the thickness values by quadrant or hemisphere, misinterpretation of shadow artifacts, and the red and green disease. So what is the red disease? Red disease is misinterpretation that occurs when a normative database is applied to patients who should not be considered normal, say as for example people who have high myopia, where the RNFL by itself is thin, and all this that you see on the OCT graph pattern is actually because of that and not because of glaucoma. So you need to be careful of that. That's the red disease. And the green disease is there are certain focal losses which happen, which actually the OCT cannot predict because the OCT actually takes the average calculation of the thickness map. So these actually can confuse you, and you can have a totally green OCT there where actually the patient does have focal losses which are not picked up. So red and green disease, high myopes, measurements tend to fall outside the normal range, showing up as red. On the other hand, small focal areas of damage in any eye often show up as green because the instrument averages the thickness in a particular sector. So there's a need for taking artifacts into consideration when interpreting the data from these equipments. So device-related artifacts, absence of eye tracking system causes this not controlling of the head tilt, absence of robust segmentation software in the OCT, and failure to recognize non-glaucomatous disease such as my other speakers will be talking to you about, anterior ischemic optic neuropathy, retinal dystrophies, and hemiretinal vein occlusion, amongst others. So if you look at that misdirection artifact, vitreous retina interface is misidentified as the outer surface of the retinal nerve fiber layer, so that could lead to a misinterpretation. And similarly here, false progression artifact, release of epiretinal membrane is noted. This is here, and then when you look at this, which creates a false appearance of progression that the clinician may miss. Then we move on to the masqueraders of glaucoma such as neurosyphilis, optic dysdrusen, and optic neuropathy, which will be dealt by my subsequent speakers, so I wouldn't go into those details. So points to be considered, clinicians must pay attention to the quality of the strength and the signal strength. Factors that decrease signal strength I've spoken to you already about, artifacts and data acquisition and segmentation areas. The drawbacks, artifacts and anomalies of the scanning process affect all the machines due to inherent drawbacks or limitations in the machine hardware or anatomical variations in the individual patients. So it's important to recognize the common sources of error and avoid them in clinical practice. These I've already spoken to you about. So progression of on the OCT is not defined unlike the case of visual field tests, and hence it has to be subjectively interpreted, keeping in mind the limits and resolutions of each individual machine. All OCT devices do not have the ability of fast grace track and alignment hardware and software for progression, and so have a limitation on their use on follow-ups. So another challenge which often poses is the early glaucomatous change, which includes the macula. So by the macula, we mean the region of 8 degrees of fixation, which is only approximately 2% of the retinal area, but includes over 30% of the retinal ganglion cells. Each macular damage is missed or underestimated by the OCT disc scan, especially if metrics such as global quadrant or clock hours is taken into account for RNFL thickness. So most clinicians use the disc scan. And the challenge too is here, in most of these cases, we say the OCT is useless when in advanced glaucoma. But if you look at this, where it shows that, this 24-2 visual field shows a region of preservation, whereas the corresponding region in this area can be seen. You can pick it up actually if you look at it carefully instead of going by the numbers. So these are the two challenges that suggest a radical change should be made in the common clinical paradigm that the OCT uses, and maybe visual fields which include the finer test grids like 24-2C or 10-2, etc. should be actually equated with the OCT and seen in advanced cases. So are we in the middle of a paradigm shift? At a glance, clinicians need to confirm a few rules to accurate optical coherence tomography imaging before accepting the results. I've already told you about all that. And when assessing progression, you must determine whether the changes are clinically significant or not. Do not rely on the OCT. Always use your clinical eye before you label a patient as progressing. Thank you very much for your attention.